Thank you very much. Yes, I stand between you and coffee. It doesn't really enhance the popularity of a regulator, perhaps. We're running 10 minutes late. I shall be brief. Thanks for the opportunity. I'm delighted to be here. I thought it was going to be challenging enough to speak after the Cabinet Secretary, but to speak after Alan Baird being the Cabinet Secretary, and to speak after Donald's passionate and inspiring presentation about the importance of locating what we do in a human rights framework, and to congratulate the people who've undertaken that significant and important piece of work. Some of what I'm going to say will hopefully make connections with that. It will certainly build on what Bridget and David said to some extent. I want to start by very briefly, and I'll move through quite quickly the first few slides, outlining the work of the Care Inspectorate, because many of you will be familiar with our statutory responsibilities for providing public protection and insurance. We register care services, we inspect them, we investigate complaints about them, and we also have a statutory responsibility under the Public Services Reform Act for furthering improvement, and I'll say a little bit more about that as we move on. We also carry out joint strategic inspections of services for adults and children with others, with Healthcare Improvement Scotland, with Education Scotland. And there are important links there that we need to build on, and we're reflecting on how we do that. So we register and inspect 14,000 care services in Scotland, amongst which house and support, care at home, but obviously the broad range of services, from everything from secure care for children to childminders, to care homes to nurseries. In relation to registered care at home services, I wanted to see how the numbers have evolved over recent years. So there has been a growth. There's been an increase in the number of registered care at home services in Scotland over the last 5 years. 252 services have cancelled, but 408 new services have registered. So we've gone from, in 2011, 792 services up to 950 almost services now. So it's an area of growth. It continues to be the cornerstone of the efforts that we are making collectively to try to support people to live safely and independently at home for as long as possible. But I don't underestimate the challenges, and I'll mention some of those as we move on. I thought it might be useful to look at some of the grades that we've evaluated these services against in relation to the last 5 years. And I've grouped them together. Our grades are 1 to 6, you'll be familiar with them. From 6 is excellent, 5 very good, 4 good, 3 adequate, 2 weak, and 1 unsatisfactory. So you'll see there that in relation to the theme that we look at the point of inspection around quality of care and support, there are fewer services most recently, and these are snapshots from the 31st of March in the respective years. There are fewer services now attracting the higher grades in relation to quality of care and support, excellent and very good. But there are still 56% of services attracting those grades, and there are still 42% of services that are adequate or good. The numbers of services that are weak and unsatisfactory has reduced. So I think quite a positive message. And that's further found in relation to the evaluations that we make in relation to the quality of staffing of care at home services, where you'll see that more recently, more services are attracting higher grades in relation to the quality of the staff and the services that they're delivering. Again, a positive message. Similarly, in relation to quality of management, we're seeing some shifts. A slight shift in relation to fewer services now are attracting the grades of adequate and good, but we've clearly got a good spread there, and a lot of services continuing to deliver really good, positive approaches in relation to staffing, in relation to quality of care, and in relation to the management and leadership of those services. So, to consider innovation, I had a lot of thought about this, and I wanted to firstly reflect on whose role it is to support innovation and what that role involves, the extent to which it is the responsibility of ourselves as the regulator, as the Care Inspectorate, recognising that our responsibilities are around scrutiny and providing some assurance that we register, we inspect, we investigate complaints, we apply enforcement activity, but that we're also involved in improvement. I think we do have a significant role to play. I'll come on to mention what I think that involves moving on, but building on some of what's already been said, I think also commissioners and service providers have a role, a responsibility and an opportunity to co-produce innovation in relation to the social care market. Commissioners should be anticipating and aggregating future need. They should be linking national and local policy to their priorities. They should be thinking about the opportunities that integration brings, and they should be managing the local market so that they are bringing to that market opportunities for innovative new services to meet those policy objectives. Commissioners, though, are having to deal with the consequences of austerity measures. The public purse is under significant pressure. There are challenges around the application of eligibility criteria and prioritisation. And at this point, they are in the midst of delivering on the implementation of their integration models, and that is not, in some areas, without significant challenge. They have reduced capacity as a result of some of the financial challenges they've experienced. And there are particular issues around their operating costs. But that's not unique to them. Many of those characteristics you will be absolutely familiar with, because they're the situations that you're having to manage if you're a service provider day in, day out. I think those service providers have the opportunity, as I think we've heard earlier, to bring new services to the market, to present innovative solutions, to provide opportunities to try new things, to engage in a way with commissioners that discusses and debates how can we address some of the priorities in each of the localities. But you're challenged too in relation to what we've heard about the Scottish Living Wage, about increased operating costs, challenges around the cost of sleepovers for those of you who provide that type of service, concerns about not being able to pay travel time, and challenges around framework agreements and around contracting and commissioning activities. So I wouldn't in any way want to underestimate the operating context that you're having to deal with. And I suppose on one hand it begs the question, in that context, how can we afford to innovate? Potentially a question could also be posed in that context, how can we afford not to innovate? Albert Einstein's already made an appearance. If we always do what we've always done, we'll always get what we've always got. So I think some of those pressures and challenges have to provide a catalyst for us to think about and imagine new ways of delivering services. And some of that is able to be done, and some of that is being done, and I'll say a little bit about that. So the first part of that, commissioners and service providers, I suppose, was about innovating service models. The other bit, I think, is about thinking about innovating practice and approaches. And therein, there is also a responsibility on various partners, and there is also an opportunity to co-produce. The relationship between care managers who are doing assessment and care management, service users, people who have support needs, and service providers creates opportunities for that sort of co-production and innovation in relation to how you will provide my support. And I'll say a wee bit more about that. Bridget mentioned the key findings, I think, from the Guardian social care research that talked about how 1,000 people were surveyed, over 1,000 people were surveyed, and what they identified was that in terms of providing, receiving care and support at home, they wanted three things. They wanted friendly, respectful staff, they wanted time for care, and they wanted choice about services. These are not, perhaps, one would think, too much to ask. These are important considerations that are reflected in the convention. They relate very much to what Bridget and David was saying earlier. The bit about friendly, respectful staff, I think it's interesting to note the recent publication from Skills and Care, which highlighted that increasing numbers of employers are moving towards value-based recruitment, where they bring into their organisation people who have the right value base and then give them the skills. And that serves better in terms of sustaining and retaining staff and enabling them to deliver the types of services that are needed. So what of the regulator in all of this? Our role in relation to supporting innovation. We don't bring new services to the market, but what we can do, and increasingly are doing, is engaging at an early stage in discussions with providers and commissioners about what those services might look like and what are the challenges and opportunities that the legislation that we're responsible for implementing can deliver. So, for example, we are acutely aware that some of our registration categories and some of the regulations in the legislation is a number of years old now and can present a barrier to some of what is seeking to be delivered, particularly through, I think, self-directed support, but through other models. So our registration colleagues will work very keenly with providers at an early stage in order to have a discussion about how jointly we can negotiate through any of the challenges that might be presented by the registration categories or the regulations. We're gathering a body of evidence that is going to support us in our discussions, which we have now begun with the Scottish Government, about whether we need to think differently to the categories that are included within the Regulation of Care Act, and whether or not we need to be developing those in a way that makes them more fit for purpose and more responsive. So that's something that we can do and we can contribute. In relation to the innovation of approaches and practice, it's really up to us to ensure that our inspectors have a really positive can-do attitude, that they're risk-enabling, that they're open to hear what it is you're trying to achieve, and that they're working with you to support that. And I think there are examples of that, and there will continue to be examples of that moving on. Swaran, how long do I have? Okay. So I have some examples in relation to each of these. I've taken from inspection reports where there are really good examples out there of how technology is supporting innovation, how approaches to the delivery of care and support is building on what's already provided by unpaid carers and ensuring that their contribution is still key to enabling the supported person to live at home. Enablement is key. There are really good examples there. Integrated working, where we've heard about some quite practical examples. I wish I had a slice of toast in my slide here. But to get people to reduce the duplication, to reduce the numbers of different people going into households, health and social care provides an opportunity to be a catalyst for that type of integrated working. And there are some examples already emerging. Key is the bit about community connectedness, about ensuring that services support people to regain and resume contact with their local community, to support people to be active citizens, to support people to have connections, to have supports when the statutory services or the commission services leave. Self-directed support, there are some really good examples around self-directed support. It's emerging, it's early, it needs to be bigger, it's going to be bigger. It connects with that bit about respected and valued staff. It connects with that bit about how much time people are being provided with in terms of their support. But it critically connects in what type of support is delivered when, by whom. And you have a contribution if you're a service provider to self-directed support. You should see it as an opportunity. You should see it as a way in which you can extend the portfolio of service offerings you're bringing to the market, that you're offering commissioners, and that you're looking to engage in discussions with individuals who are supported about in new and different ways. There are also some examples of services that are developing support around physical activity and exercise. I won't go through the detail of all of these, but these are the types of considerations that we're already finding in relation to innovative approaches to home care. We're also trying to innovate ourselves. As a regulator, we can't demand that others consider their capacity and their commitment to improvement without reflecting on whether we can. We are moving from a position that previously would have perhaps been focusing on a compliance-based approach to our inspection and regulation, to thinking about working more collaboratively, to engaging with providers and having conversations about how can we work and support you to develop better services to improve your offering. This is about our commitment to further improvement. This is born of a recognition that providers generally want to do a good job are doing a good job and are looking for guidance and support to build on that. So we'll signpost people to best practice. We'll give you examples of what it is we're looking for. We won't just come in and apply a requirement. A year ago, we developed our excellence in care development around not only applying a requirement following an inspection if there was a clear link between what it was that we'd found as a deficit and outcomes. So we're taking a more proportionate and risk-based approach to that. We're moving also from enforcement to improvement. So it's that bit about not being in a position where we want to impose improvement notices or requirements, but actually being much more explicit about what it is we think looks like good examples of practice, signposting you to that and working with providers. We will still retain the right to take an approach in relation to enforcement if there are clear risks to service users and if there is clear evidence that hitherto you have struggled to demonstrate a commitment or a capacity to improve. We won't balk at those difficult decisions, but we are much more focused on collaboration and improvement now. This, I suppose, summarises some of that in relation to taking a more proportionate and targeted approach to inspection, more focused on outcomes, supporting improvement, and moving to consider the impacts and implications of policy. So from this year, for example, we're going to spend less time inspecting services that are consistently performing well, and we're going to focus activity and attention on those that are performing less well. We're no longer going to be focusing on all the quality statements. We're going to be looking at the high-level themes, and we're going to be linking them to outcomes. We're going to deliver shorter and clearer reports. The evidence will be there. It might not be necessarily included within the report. We can give you the evidence at feedback. We can discuss the evidence out with that process. The reports are about signposting the public to services, to providing some assurance, and to helping people make decisions about what services they may wish to take. And my slide doesn't show this on the screen here, but there's a focus on dementia. So we're looking at 150 care homes across Scotland this year. We may take that to care at home next year, where we're focusing on the ways in which those services are meeting the needs of people affected by dementia. We're considering their approach to the implementation of the dementia standards. We're considering how they're developing dementia-friendly environments in relation to the King's Fund standards. We're concerned about end-of-life care. We're concerned about oral health. There are other aspects that we'll be looking at. So we offer support and improvement advice through our health improvement teams. That has been found to be really helpful. We have experts, specialists, advisors, consultants in relation to these areas, and we secure support from others. These are services that grow capacity within our workforce in terms of understanding some of the complexities and specialisms, but they're also outwardly facing and able to provide support to providers where that's felt to be necessary or of value. We've also got a hub, something called the Hub, which is a portal that showcases examples of good practice, innovation. I'd encourage you to look at that. There's lots of examples of how services are delivering innovative approaches that link to outcomes, and we hope to grow and build on some of those, some of which we will get from the examples that I've got, some of which we might get from the awards that are given out tonight. Our stall over there has examples of all the improvement resources. Edith McIntosh, our rehabilitation consultant, will be unhappy that the one on managing falls and fractures has been superseded by one that was published a couple of weeks ago. I have a copy of my presentation in my pocket with the new slide, but I didn't get the chance to upload it, Edith. And finally, we are charged with the responsibility by Scottish Government for leading, along with Healthcare Improvement Scotland, the development of new national care standards. The current standards are 12 years old. They're based around various settings rather than people. The new standards are being developed in partnership. Scottish Care are involved in all levels of that development. The new standards are going to be firmly grounded in a rights-based approach, so we'll look for read across to the convention. We've now published, the Cabinet Secretary has agreed, the high-level principles. Those were published in April. Examples of what they are, the details of them are on our stall, so if you have a look at that. At the moment, we're developing general standards that sit below the high-level principles, and as I say, Scottish Care has a significant contribution to make to that and is continuing to do so. And then there'll be specific or specialist standards developed through time. The very astute providers amongst you, of which I suppose that's you all really, isn't it? Because that's why you're here. Will work with us on this, but we'll also anticipate that once these standards are published, we will be inspecting against these standards. We will work with you to identify what we would be looking for in relation to evidence pertaining to each of the standards, but you might begin to think about anticipating how you're developing some of your approaches in light of these standards. There's a website, there should have been a stall, I don't think I've seen it, and there's more information available. So, thank you very much. I hope you enjoy your coffee.